Okay, excellent. Today, inshallah, I'll be talking about regional radiotherapy, and we're going to go about the benefits of regional. We're going to touch upon some tips about volumes and doses. With any treatment, our aim is usually to improve the outcome and minimize the toxicity. And the same in breast cancer for regional radiotherapy. If you want to look at its benefit, we have first to go back a little bit into the older trials. And when I say older, I'm talking about the 80s. So we have to mention about the Danish BCG 82B and C, as well as British Columbia trials. They basically took node positive patients and randomized them to post-mastectomy RT versus no post-mastectomy RT. Those who were premenopausal got chemotherapy with CMF, and those who were postmenopausal received tamoxifen. With a median follow-up of 10 to 20 years, there was an absolute 10% improvement in overall and about 2/3 reduction in the risk of local regional recurrence. And note, the post-mastectomy RT here was including the chest wall, axilla, supraclav, infraclav, and IMN. However, some major criticism of these trials included inadequate surgical axillary management with now outdated chemotherapy, suboptimal duration of tamoxifen, old radiation techniques at the time. Never of the predictors of local recurrence and from the Danish trials. They group and groups with the poor group having 2 out of 3. More than 3 positive nodes, T3 or grade 3, and those in the good group having 4 out of 5, 1 to 3 or EPR positive and HER2 negative. And when we look at the local recurrence probability, it is significantly improved with the addition of post-mastectomy RT, with the largest absolute benefit in the highest risk group of 36% reduction in the local recurrence probability. Who would have survival benefit from the local regional radiotherapy? We have the EBCTCG meta-analysis about the benefit of regional radiotherapy on 10-year recurrence and 20-year breast cancer mortality. They included over 8,000 patients in the trials that took place between 1964 and 1986, so the older trials. And they found an absolute benefit in all of the outcomes in terms of local regional recurrence, any first recurrence, and breast cancer mortality, whether the patient has 1 to 3 positive nodes or 4 or more node positive disease, with 20-year gain of 8 to 9%. But there has been a lot of advancement in the breast cancer management over time, from surgical techniques to systemic advancement. And so we have to look at the more modern trials in early stage breast cancer. And the first 2 trials, Dr. Al-Amran already has touched upon this, so it will make it easy to go through. The first one is the ERTC 22922 trial, basically taking node positive patients or node negative with central or medial tumors and randomizing them to internal mammary medial supraclav RT versus no internal mammary medial supraclav RT. About 1/4 of patients had mastectomy and the rest had lumpectomy. There was a bit over 4,000 patients. And I want you to note here that the percentage of patients with N2 or N3 was 13% or less. And those with N0 disease were 44%. So mainly we are looking here at N0 or N1 patients. At 10 years, there was a 3% absolute reduction in the 10-year disease-free survival and metastasis-free survival, and 2% improvement in the 10-year breast cancer mortality, but this did not translate into overall survival benefit. However, I want you to keep these numbers in mind, because as we go along, this number will keep coming back. There was a bit of increase in the lung fibrosis at 10 years at 4.4% versus 1.7%. However, the cardiac and other toxicities were similar between the two groups. The same trial update at 15 years was published in the Lancet 2020 and showing that there is year breast cancer mortality and 2.6% improvement in any breast cancer recurrence. However, again, there is no overall survival benefit yet. If we look at their 15-year toxicity results, there was a bit of increase in the pulmonary fibrosis and cardiac disease. However, if we look at the score 2 or more side effects, which are clinically relevant, then we find for cardiac 1.8 versus 2.6, for the lung 0.1 versus 0.8. So we're talking about less than 1% with the radiation in the to internal membrane. And here you can see that there is overlap of the curves for all of the three toxicities. Moving on to the MA20, there was a bit over 1,800 patients who were early stage node positive or high risk node negative. Again here, so it is more difficult to generalize the result of this trial on this subpopulation of patients. All node positive patients had dissection, and all lumpectomy patients were, this trial included all lumpectomy patients. Most patients had one, and only 5% had N2 or worse. More than 90% had chemotherapy, and also over 80% had endocrine therapy. At 10 years, there was a 4 to 5% and distant metastasis disease-free survival, as well as 2% improvement in breast cancer mortality, same number that we found in the ERTC trial, although here it did not reach a statistical significance. Also, there was no improvement in the 10-year overall survival. If we look at the toxicity, there was a bit of increase in the pneumonitis at 1.2 the irradiation, and a bit of increase in the lymphedema at 8.4 versus 4.5. So here I want to say that most patients in this trial had 1 to 3 positive nodes. So it is likely that patients with more than 3 nodes were routinely treated of detecting a significant effect on overall survival. And in addition, since the majority received contemporary chemotherapy with anthracycline or taxane and endocrine therapy, the baseline risk of death and the power to detect the group improvement in overall survival were probably further reduced. Now, all of this does not yet inform us about the value of internally. We have to look at the Korean trial, the KROG 0806, which took node positive patients, about 735 node positive patients, randomized them to local regional radiation with or without IMN. So really looking just at the value of IMN. Most had chemo and endocrine therapy, and at 7 years, the disease-free survival was around 82% without IMN irradiation versus 85% with. And so there was a 3% difference in the disease-free survival, although not as statistically significant. There was also unplanned subgroup of iron. There was also pneumonitis. Here we can see that the persistent metastasis, free survival, regional recurrence rates were also improved by approximately 3% with the addition of internal mammary nodal irradiation, but they didn't reach statistical significance. Of note, there was a major issue of power in this trial, as stated by the authors themselves, and because they overestimated the difference between the two groups. And in conclusion, this trial, although it raised the possibility of improvement in disease-free survival with regional nodal irradiation, but this was not statistically significant due to loss of statistical power. Moving on to the other one, the study, it was a nationwide prospective population-based cohort study. And it was testing the effect of radiation to IMN in early stage. All of them with left-sided irradiation, cancer, mammary nodal irradiation characteristics. Most of patients were T1, T2, and about 60% had N1 and 40% had N2. So good proportion of patients with N2 disease. At 15 years, there was a 5% absolute improvement in the overall survival with the addition of internal mammary nodal irradiation, and about 2 to 3% improvement in the distant recurrence and breast cancer mortality. This study, again, included only node positive patients, 40% of whom had pathological N2 or N3 disease, and all of whom were allocated to systemic treatment. So the prognostic differences most likely accounted for the higher event rates and may, in addition to more intensive use of systemic therapy, explain the more profound effect of internal mammary nodal irradiation on survival. If we look at mortality by cause of death, there was not any significant difference between the two groups. So trying to put all of this together, we have the EBCTCG meta-analysis of individual patient data that looked at the role of regional radiotherapy in over 14,000 patients. What they did was newer. So all their trials took place between 61 and 78, and then there was a 10-year gap. And then the newer trials were from the 89 to 2008. And in this 10-year gap were the initial studies that we talked about, which were the Danish and BC trials. If we look at the differences between the older versus newer trials, of course, we find that the technique has shifted from field-based with RQA, just newer. Also data for half patients in the older trial versus over 96% in the newer. And we can see the shift or migration to more breast-conserving surgery, more chemotherapy, and more endocrine therapy. If we combine and average the results, so from all trials, older and newer, we find about 2.4 to 2.6% improvement in any first recurrence and breast cancer mortality. But if we look at the newer trials, we find a 2.6 to 3% improvement in the any first recurrence, breast cancer mortality, and overall mortality, with no statistically significant difference on breast cancer mortality. and their effect of nodal irradiation, which was greater for women with medial or central tumors than those with lateral tumors. Here, for women with 1 to 3 positive nodes, regional nodal irradiation reduced their absolute risk at 15 years for breast cancer mortality by about 2 to 3%, and this has increased to 4 to 5% in those with 4 or more city. In terms of lymphedema, generally speaking, supraclav or internal memory nodal irradiation shouldn't cause lymphedema, and only MA20 provided lymphedema data. And we talked about this earlier in the MA20 trial. And radiotherapy had no significant effect on heart disease mortality, second cancer incidence, or contralateral breast cancer incidence, or non-breast cancer mortality. So to conclude this part, for node-positive patients, local regional radiotherapy is associated with 2 to 5% improvement in disease-free recurrence and breast cancer mortality. Now, what about node-positive patients following sentinel lymph node biopsy or node negative patients? For clinically T1, T2, and 0 patients who are found to have positive sentinel lymph nodes, they were randomized Z11 to axillary dissection versus we're supposed to be 1,900 patients on this trial, but it closed earlier with half of the patient due to not enough events. And as Dr. Al-Amran already showed the trial results at 5 years, there was similar overall survival and disease-free survival between the two groups. And also the 10-year, this is here showing the 10-year updated analysis. It was also reassuring and showed continuing low rates of axillary relapse and no significant difference in local regional recurrence. Also, if we look at the original relapse-free survival, it was not that much different between the two groups. Here, I want to note that we know some of the patients on this trial, about 50% had high tangents and 18% had local regional radiotherapy. And despite that, it is still unlikely that this has been responsible for equivalence of the clinical outcome and non-inferiority being maintained at 10 years of follow-up. The other one is the AMAROS trial that took the same group of patients and randomized them to axillary dissection versus axillary radiotherapy. And from this, we learned that if the sentinel nodes are positive, then the risk of having further positive nodes is 33%. The 5-year results was reassuring with low rate of axillary recurrence in both arms, but no statistically significant difference between the two groups, and lower rate of lymphedema in the axillary RT group, with no difference in overall survival and disease-free survival. And here in the bottom schedule, you can see that the 10-year results are also similar with no difference in the disease-free survival or local regional recurrence. However, which require first a part of patients with high burden of axillary disease who have poor risk and might safely be spared comprehensive axillary radiation. There is evidence from these episodes may be unnecessary for sentinel lymph node biopsy positive patients with limited disease in the sentinels. It should be noted that AMAROS trial did not include a non-intervention arm. And although axillary radiation is non-inferior to the dissection and associated with reduced morbidity, evidence suggests zero treatment at all. But this is not yet anything to practice because still trials are going on and we just have to keep an eye. For node-negative patients, we have good understanding for the risk factors for local regional recurrence post-mastectomy hysterectomy, including LVI, grade 3, large T. I would also add are negative or triple negative breast cancer. And those with collection of risk factors have local regional recurrence with the patient about the pros and cons of regional radiotherapy. For node-negative patients post-breast conserving surgery, we already seen that M820 trial only included less than 10% of these patients, so it's hard to generalize. But the EORTC had a good proportion of these patients, and Dr. Al-Amran already talked about this. Now, what about after neoadjuvant chemotherapy? The optimum axillary management and the role of axillary radiation remains unclear and continues to evolve. However, there is general consensus that those with clinically node negative and negative then sentinel lymph node biopsy post-neoadjuvant chemo do not require those who present with advanced stage 3, like T4, N2, N3, or those with residual nodal disease post-neoadjuvant chemo or residual large tumor post-neoadjuvant chemo, they require local regional radiotherapy. Now, if we look at the clinical N1 patients, pre and post-chemo, axillary dissection and regional nodal irradiation remains a standard of care, and we're looking for the Alliance trial results to come up soon, inshallah. Now, the dilemma is more in the clinical N1 pre-chemo and N0 post-chemo. Now we have better understanding of the role of sentinel lymph node biopsy in these patients, but the role of regional radiotherapy is more controversial. This Dutch prospective registry study was the first one to suggest safety of the selective de-escalation of radiotherapy post-neoadjuvant chemo. So basically, they took clinical T1, T2, N1 disease who were treated with chemotherapy and surgery, and they included over 800 patients. They grouped the patients into 3 risk groups for local regional recurrence based on predefined criteria with corresponding local regional radiotherapy recommendations. Those in the low risk group had no chest wall or regional irradiation. Those in the intermediate risk group only had local radiotherapy, and those in the high risk group had local regional RT. Overall, at 5 years, the rate of local regional recurrence in all patients was only 2.2% with this policy of response-adapted radiotherapy. Coming to the NSAB PB51, which was well awaited, and for those who may not be familiar with it, it included patients with a clinical N1 disease who converted to YPN0, and patients were randomized into regional nodal irradiation versus no regional nodal irradiation. Initial results were presented in San Antonio Breast Cancer Symposium last year and absolutely showed no significant difference in the primary or secondary outcomes, not the invasive breast cancer recurrence-free survival, not the isolated local recurrence-free interval, not overall survival or disease-free survival, not whatsoever. However, this is very difficult for all of these patients. First, we need more follow-up and full publication. And second, we have to be cautious, as for example, here in the younger with more aggressive disease and in the West. So we have to be cautious. Although it's coming, we know some group of patients don't require regional radiotherapy, but we have to be cautious from generalizing this to all patients. There is also another ongoing trial, ANTEC, in the UK. Also, those patients, clinically N1, converted to YPN0, but the beauty of this, they were randomized to either observation following sentinel lymph node biopsy or further axillary treatment, which could be a completion of axillary dissection or axillary radiation. Now, Dr. Al-Amran beautifully talked about volumes, but I have some extra tips on those. We all know the RTOG Atlas. We have the Danish Atlas. There's one very nice, the Taylor here with the Taylor RT is a trial from MA20 and his group, and they are trying to see if there is a role for de-escalating treatment in those with node positive and low risk disease. But they have a beautiful ring. So we're all familiar with this RTOG tables. I'll skip this, but I want to highlight some of the less clear, let's say, defined margins for lymph nodes. For example, in axillary level 1, the caudal is the pectoralis major muscle inserting into the ribs. And in the Taylor RT Atlas, it helps us define this area by identifying the 4th and 5th ribs when they come off the vertebral body. And then we follow them to the mid-axillary line. So if we have the 4th and 5th ribs here in the mid-axillary line, this is where we start contouring the caudal level of level 1 lymph nodes. Also, please note that these fat spaces here and there don't need to be contoured because they can increase the width of the tangents and then increasing the lung toxicity. If we move on to level 2, as Dr. Al-Imran mentioned, we have to include the rotor's node, which is between the PIC major and minor. So we have to go from the posterior edge of the PIC major to here the ribs and muscles. And if we want to look at level 3 lymph nodes, we have to identify the PIC minor and then contour medial to it. Again, here, this is the PIC minor, and you have to contour medial to it, and you need to refrain from contouring all of this space. Moving on to the inferior border of supraclav lymph nodes, a bit of anatomy here. We have brachiocephalic dividing into the superior vena cava, brachiocephalics, and then subclavian and internal jugular. This anatomy is best seen on coronal view. And if you scroll from anterior to posterior, you will be able to appreciate the brachiocephalic, and then here it's going to be arching the subclavian and then the internal jugular vein going up. And so this is the caudal border of the supraclav lymph node, which also corresponds to the caudal edge of the clavicular head. For internal mammary nodal CTV, it includes the internal mammary / thoracic vessels in the first 3 intercostal spaces. Although if you look at the Danish atlas, you will find in the first 4 intercostal spaces. So this is again from Taylor RT. Here on this sagittal view, you find the clavicle, the manubrium, and then here the first 3 intercostal spaces, 1, 2, 3. For doses options for local regional radiation, standard fractionation with 45 to 50.4 is an option for patients who undergoes or will undergo reconstruction or re-irradiation. Although we have some evidence now from Fabric trial that was presented in Astro 2023, and it's assuring regarding the use of hypofractionation in the setting of reconstruction. Also, another trial, the MAC 23, is pending. The other option in other patients will include hypofractionated regimen. Ultra hypofractionation is not yet for local regional radiation, although Fast Forward is having another study testing the ultra hypofractionation regimen in this group of patients. So in conclusion, local regional radiotherapy is indicated for node positive and high risk node negative patients. And generally, it should include internal mammary nodes, and the role of regional nodal irradiation in the neoadjuvant setting is evolving, and we have to keep a close eye. With this, I conclude and thank you very much for your attention.